Good morning, everyone. Thank you for joining the CCIH virtual conference. Our discussion today is on faith, hope, and love, 50 years of practicing community-based primary healthcare in Nicaragua. My name is Dr. Roberto Martinez, and I'm currently the AMOS Board of Trustees, the chair of the AMOS Board of Trustees. We are going to wait a couple of minutes while people join in, but we are very, very excited to share our story. We have a great set of panelists from our organization. We will be introducing them shortly. So stay tuned with us as we stream live this presentation. We are very grateful for technology and for allowing us to, through the internet waves, meet one another and share our stories. So let's wait for a couple of minutes while other people join us. So once again, for those who are joining us just now in our YouTube channel, welcome to this virtual conference of the CCIH virtual conference. And you are joining the discussion on faith, hope, and love, 50 years of practicing community-based primary healthcare in Nicaragua. We're just waiting a few minutes before we can introduce our panelists and the story that they have to share. So stay tuned with us. And if you're new to CCIH, you should know that this is an international network of approximately 115 Christian organizations and 15 secular partners, as well as a few hundred individual members. CCIH's mission is to promote health and wholeness from a Christian perspective and provides opportunities for capacity building, networking, sharing best practices, and advocacy. So thank you so much for joining this virtual CCIH conference, and we'll continue to wait maybe 2 more minutes, and then we will get started with this presentation. Well, good morning, everyone, and thank you again for joining CCIH conference session. My name is Roberto Martinez, and our discussion today is on faith, hope, and love, 50 years of practicing community-based primary health care in Nicaragua. Thank you for joining again. And our platinum sponsor for this for the CCIH conference, Abbott. Abbott is a global healthcare leader that helps people live more fully at all stages of life. Their portfolio of life-changing technologies spans the spectrum of healthcare, with leading businesses and products in diagnostics, medical devices, nutritionals, and branded generic medicines. And their 107,000 colleagues serve people in more than 160 countries. So we thank them for their support. And this week of the conference particularly is sponsored by our gold sponsor, Cure International. Cure International's mission is healing the sick and proclaiming the kingdom of God. Cure International operates charitable hospitals and programs in 14 countries worldwide, where patients experience the life-changing message of God's love for them. Cure specializes in providing surgery to children to treat conditions such as clubfoot and other disabilities, untreated burns, and hydrocephalus. We thank them too for their support. As far as the flow of the program today, please feel free to type questions into the chat to the side of the video on YouTube. In order to post a question, you do need to be signed into Google and have a YouTube channel. So even if there are no videos on it, if that's a problem for you, you're welcome to email questions to webinar@ccih.org. I repeat, webinar@ccih.org, and we will get them that way, and we will try to answer as many questions as we receive them. So please feel free to post your questions when you think of them, but we will hear the presentations first before opening it up for Q&A. This webinar is being recorded and will be posted on the CCIH YouTube channel in a conference playlist. And you will find links to the recordings on the CCIH website at www.ccih.org. My name is Roberto Martinez. I currently serve as the chair of the AMOS Board of Directors. I'm also currently a PhD student in epidemiology and biostatistics in the Department of Population and Quantitative Health Sciences at Case Western Reserve University in Cleveland, Ohio, here in the United States. And I live in Cazenovia, New York, a very small town south of Syracuse. So it is my pleasure to introduce the panel, Faith, Hope and Love, 50 Years of Practicing Community-Based Primary Health Care in Nicaragua, and its panelists. As I introduce them, I just want to share one brief story. For over 50 years, AMOS has used a community-based participatory approach to empower rural communities and provide community-based primary healthcare services to reduce infant and maternal mortality in Nicaragua. So the dream for AMOS began in 1967, and in the following slide, you will see Dr. Gustavo Parajon, a physician and medical missionary, and American Baptist pastor. It was the previous slide. In this picture, what you see him helping administer a vaccine to a young child in a rural community in Nicaragua. Upon his return from medical training in the United States, and while serving as medical director of the Baptist Hospital in the Nicaraguan capital in Managua, he made weekly travels to faraway rural communities to see patients. He soon was hit by a harsh reality. By the time he returned for a second visit to the community, children that he had seen as patients in a prior visit had died of preventable diseases. This clinical model of service provision was not working, and it was evident to him that the community needed to be empowered and developed to avoid preventable deaths of children and mothers. So this vision for empowerment gave birth to an integral healthcare initiative devoted to local leadership development, focused on communities themselves, teaching local people to provide basic primary healthcare services to reduce unnecessary illnesses and death. And this is what AMOS is all about. The model AMOS is grounded in the scientific theory and experience of researchers and programs implementers around the world, and it's effective at reducing infant and maternal mortality. And in the next slide, you'll see that this model addresses three key issues. The first one is high maternal and infant mortality. And by the way, what you're looking at there right now is the barefoot doctors and the Russian Fettler, which are prior community health worker models used in the world. So in the next slides, you see that this program addresses three key issues. One is high maternal and infant mortality. Second, that the overall effect of disease-specific interventions, for example, of malaria, on the health of vulnerable populations in developing countries has been questioned. And finally, that the transplantation of hospital-based systems from industrialized countries to developing countries that does not address the social determinants of health, the actual root causes of poor health. Without further ado, I would like to introduce Dr. Laura Parajon. She is the strategy officer and co-founder of the nonprofit organization Fundación AMOS in Nicaragua, as we know her, or AMOS Health and Hope, our 501c3 organization here in Nicaragua. She and her husband, Dr. David Parajon, based in Nicaragua. AMOS is also dedicated to using community-based and empowering approaches to contribute to the reduction of health disparities in Nicaragua. Thank you, Dr. Laura, for sharing your work.
Very excited to, oh, sorry, am I muted? Hi, can you hear me? Great. Okay, so on the next slide, I just wanted to share with you that, first of all, the title of my presentation today is Health System Strengthening, a Community-Based Approach to Organizational and Community Empowerment for Community-Based Primary Healthcare. And I'm so grateful to be with you here today, representing our amazing team in Nicaragua, and we'll share the way that AMOS has been using this methodology of community empowerment and effective partnering practices into our organizational DNA. So on the next slide, you'll see that in this slide, I actually have a passion for community empowerment because as a family physician, I feel like we were trained to see one patient at a time and got really good at treating patients like these little babies here with diagnosing diarrhea and telling these moms to like wash their hands, to prevent their diarrhea without, as you can see on the next slide, in this next slide set, you can see that while we are trained so well to see patients one at a time, we're not actually trained to address the conditions that make people sick in the first place. So my passion has always been like, how do we address those social determinants of why, these moms who live in these conditions, they can't figure out where to wash their hands, they can't figure out where there's clean water because we as a society have not provided the basic things for these families. In the next slide, you'll see that, my father-in-law and co-founder of AMOS Health and Hope, Gustavo, who Roberto just talked about, was at this declaration of Alma Ata, which this is an inspirational document for many, many health providers of the world that stressed over 40 years ago the importance of addressing social determinants of health as critical to social justice and healthcare for all people. Next slide. So why isn't this document, which 40 years later they wrote another document at Astana Declaration and a vision for primary healthcare in the 21st century, when we said we would do healthcare for all people, why is it that we still don't have healthcare for all people? And the strategy that was outlined back then, which was a three-pronged strategy of primary healthcare and public health in the yellow, with multi-sectoral policy and action or effective partnership in blue, and empowered people and communities, why isn't that happening today? So we didn't just ask ourselves why, we said, how can we make this happen? So in the next slide, you'll see that out of the three strategies, primary health care and essential public health has been really well developed. So you basically will see that we have tons of protocols on how to treat children with diarrhea or, moms to do pregnancy plans. But that piece is pretty much well developed in the world of global health and public health. We're able to increase access to healthcare by training community health workers. But if you see in the next slide, oftentimes what happens is that if you see in this slide, you can see the hospital here. So much of the times we are putting more money into hospitals than we are into communities. So there'll be like more money for hospitals, then health centers, then health posts, and then communities are like a little underfunded afterthought, right? Instead of being one of the main components of how we can reach health equity to the most vulnerable people. Next slide. So AMOS has been doing a really good job of integrating primary care and public health, but one of the pieces that we also have been really focusing on is the piece about partnership and community empowerment. These are usually the missing links when we implement primary healthcare, both in the United States and in Nicaragua and globally. Those are kind of like things that get left out and be like, oh yeah, we should do that too. But at AMOS, in the next slide, you can see that we actually did that as our main thing. One of the main things we do at AMOS is partner with others, partner with churches, partner with donors, partner with different organizations to develop effective practices for collaboration, including from the Ministry of Health and the government system. So if you look at the next slide, you can see that our methodology is based off of Carl Taylor, one of Gustavo's colleagues and one of the fathers of primary healthcare, the three-way partnership model. Everything we do at AMOS is really built off all the work of community-based primary healthcare from the very beginning, right? So we're just building off, we're not inventing anything new, we're building off others. So we start with the communities and the bottom up local leaders and community members who define the priorities. Then we work with the government to say, what are the top-down policies and services that the Ministry of Health can provide? And then what can facilitators, that's the beauty of AMOS, facilitators like AMOS, churches, foundations, individual volunteers, what can we contribute to the priorities of the people to support their long-term health care? Next slide. The last piece, which is pillar number 3, is empowered communities and people. So if you go to the next slide, you'll see that the third pillar is, in order for communities to engage in partnership, we also need empowered people and communities. So a lot of our work is to focus on how to listen to communities, dialogue, and take action. That is not what we are trained in the medical field. We are trained to come in, tell someone what to do, and be like, wash your hands, take care of yourselves. But instead, we're training our healthcare providers, our team, our donors, our staff to be like, no, let's start with this whole listen, reflection, and take action together. Next slide. So it shouldn't be an underfunded afterthought, right? Community empowerment and partnership, effective partnerships should be the critical components for health for all. Number 3, next slide, sorry. So what we thought through in AMOS is that how you do things is just as important as what you do. So like the what of primary healthcare, that integral primary care piece, and how you do it with community empowerment and effective partnership is what makes AMOS really special. Next slide. We use the community-based participatory principles here from the CBPR model, which is, we'll talk about it a little bit later. Alyssa will explain it a little more. But the principles of CBPR, essentially, people should need it, people should do it, people should understand it, people should use it, and people should own it. It's a list of things that talks about how we make sure things are locally relevant, builds on community strengths and resources, promotes co-learning and capacity building, balances between like doing evaluation and doing the action, and disseminates the findings and knowledge to all partners. Next slide. So in order to do this, what we found is that you actually had to embed it within the DNA of our system. So within leadership, we had to look at the leadership piece and say, okay, you know, faith-based love and service, that has to be what we look for in leaders, and focusing on the mission and vision. Decision-making structures need to be participatory with staff to integrate local data empowering processes into the system, and then having people who are trained in this. And you know what, checklists are not just for diarrhea and other treatments. It should be for community-based processes and partnering practices as well. And then workplace systems to support these longer term processes, and a culture that we do of like weekly devotionals, celebration of community successes to really support the mission and vision of what we're doing. So that organizational development piece is very important. Next slide, please. So we found that we had to really focus on our mission. That was actually really one of the key pieces to effective empowerment, is like making sure everybody knew the mission of AMOS. Next slide. And that includes making sure people also are part of the values of AMOS, of service, respecting others, loving our neighbors, being good stewards, empowering communities for service and peace and justice. Next slide. Because of this, we focus our staff structure on having leadership that actually believes in the core mission, structures that support that, and people who really believe in service, hard work for the communities, and humility. Next slide. Okay, and then like I shared with work processes, we do checklists to say, yes, are you fostering trust? Are you listening to community? Are you promoting mutual learning? And cultures, like we have a cool like weekly devotional mission sharing and data parties to show that we are as a team working towards serving. And that's why it's stuck inside our organizational structure, to ensure that no matter who is in leadership, they follow this mission to serve the poorest people. Next slide. Once again, to get to healthcare for all, it's not just about the what, it's about the how, you know? How do we make sure every single baby is visited, every single person is cared for? How do we make sure this community who originally had no access to care now has access to care, because never again will there be in it an infant who lives but a few days or an old man who does not live out his years, because this is what we're all about. And then next slide, we'll just introduce Alyssa's piece, is that we put everything into a map so communities can understand how to do this process, as well as our staff, and Alyssa will talk more about that piece. Thank you.
Thank you so much, Dr. Laura. And Alisa Luisi serves as the Participatory Research and Grants Specialist at AMOS Health and Hope. She was born and raised in New Jersey. She studied international development at the College of William and Mary in Virginia, where she became inspired to work on community-based research approaches through membership in a health-focused action research project that partnered with a peri-urban community in Santo Domingo, Dominican Republic. And Lisa, as you come in too, we also want to greet all our participants. Some AMOS board members are watching this presentation. I see some friendly names from Nicaragua. I see someone watching from Brazil, as well in Pennsylvania, Pittsburgh, all over the United States. So you have a nice audience, and thank you for sharing.
Excellent, thank you so much, and welcome everyone. So thank you, Dr. Laura, for sharing a bit about AMOS's experience with organizational and community empowerment. And I'm now going to talk about our experience applying those same principles to the development of monitoring and evaluation systems. And I think the key takeaway here for organizations interested in constructing M&E systems that contribute to this empowerment process, as opposed to simply measuring effort and outcomes, is reflecting and acting on data with community members. This is an important way to enable ownership. When community members are able to use their own data to inform dialogue around shared health problems, they'll have more ownership of the action plans that then result from that dialogue. So the health systems building block we're focusing on here is health information systems, specifically M&E systems for health programs, and the impact or end goal that AMOS is ultimately looking for is increased health equity and collective capacity to resolve shared problems through mutually beneficial partnerships. So that means better health outcomes, better collective capacity, and better partnering practices. At AMOS, we apply a human-centered design approach to M&E systems. So that means that rather than designing systems to fix problems, we design systems for people. And this is especially important given that our M&E strategies need to be manageable for our community health workers to take a lead role in collecting and analyzing their own data. And that's where community-based research comes in, answering that question of how do we actually research and implement with people. Next slide. Community-based impact-oriented methodology is one key strategy that underlines AMOS's primary healthcare model. So our health committees are trained to take a community census every year to identify the most vulnerable community members, including children under 5, pregnant women, and people with chronic illnesses. Staff then help to analyze this data and present it back to community members for reflection. Health promoters then proactively conduct home visits with vulnerable individuals. And so building on this foundation of CBIO, AMOS has integrated community-based participatory research, which provides an outline for reflecting on that local data with community partners, listening to their concerns, and partnering more effectively. This then accomplishes several things: community ownership of data, reflection on epidemiological indicators, as well as community members' shared understandings of pressing health challenges, and the creation of action plans by community members. Next slide. So each year, our community health committees across 23 rural communities renew their CBPR conceptual models. They identify key aspects of the context they're working in, shared problems they want to resolve, partners they can collaborate with, potential interventions, and intermediate and long-term results. And this here is a CBPR model from the community of Banco de Siquia in the Southern Caribbean Coast Autonomous Region, called the RACS for short. And it's drawn in the form of the tree, so you can see the different sections of the model from bottom to top. Next slide. One key principle of human-centered design involves listening to the people that you're designing for. And this yearly updating and renewing of the CBPR model is one way that AMOS listens to our partners and puts the pen in their hands to try to share their understanding of their community's priorities. Now, I want to take you through the process of updating this model step by step. So on the left side of this slide, I've extracted the outcomes portion of the CBPR model. And we actually always start with the outcomes because AMOS utilizes an RBA framework, which basically means that we start by asking community members to identify the experiences they want to see realized in their communities, and then work backwards to identify the means and the partners that are needed to achieve those results. Long-term experiences typically include no funerals for children and no funerals for pregnant women or new mothers. And these results then become our monitoring indicators. So for example, we monitor child deaths and women who attend 4 or more prenatal checkups. To make this very concrete, I'll highlight an example of an experience that 3 community health committees in the RAX region added to the results section of their CBPR model last year. So in 2019, AMOS staff were presenting data on the number of point of consumption water filters that we've installed in the community, as well as the number of households that reported having access to their own latrine. Now, AMOS subsidizes the cost of these water filters and charges a small fee to help pay for their maintenance. But these 3 health committees noticed that the poor families in their community still didn't have access to filters in their homes nor latrines for their households to use. So they added this desired experience of everyone having access to safe water and sanitation facilities to their CBPR model. Next slide. Key elements of the context around this issue included the existence of inequality within rural communities, the presence of E. coli in groundwater and surface water, the presence of an established health committee with experience in taking the yearly census to collect the data we are reflecting on, and the history of collaboration and trust with AMOS staff. Key partners relevant to this scenario include the Community Health Committee, which makes annual and bi-monthly action plans, the community members who currently lack access to water filters, as well as installing the filters with the help. And then we also have AMOS, always forgot, which presents the community data to the health committee, as well as installing the filters with our help of our volunteer delegations and collecting a fee for the filters, typically giving about 20% back to the health committees. AMOS is also equipped to assess the quality of water if needed, but we don't actually have the experience with latrine installation. So that's something that the health committee can choose to approach the local government representatives to advocate for. And for AMOS, this is an important aspect of empowerment, communities being able to form partnerships with a variety of actors, depending on the resources those actors are able to contribute. Next slide. So finally, we get to the proposed interventions. Health committees proposed using the percentage of money that AMOS returns to them from filter purchases to offer free filters to community members who are unable to afford the fee. Now, before installing more filters, AMOS realized that we needed to take a holistic evaluation of our existing WASH program in order to give the best recommendation for the right filter to use in this context. Because over years, we had installed a couple of different kinds, and we recognized that this was the right moment to do our due diligence as a partner and evaluate the performance of them in order to give the best recommendation. So that's just one example of how our community partners use this model as a practical tool to reflect on data, define community priorities, create action plans, which our supervisors then support them to carry out. Next slide. Apart from health outcomes and social action plans, AMOS also monitors the performance of our community health workers and program supervisors to promote continuous learning and growth. And Dr. Laura already mentioned our checklists. These are a tool that we use to assess our health promoters' clinical technique, management of medicines, childhood illnesses, medical education, home visits, and community organization. So supervisors review checklist scores on site in order to give promoters immediate feedback and to build trust that AMOS is interested in helping them grow, as opposed to merely grading their abilities. And last year, we started doing this with our program supervisors as well, in order to assess their performance on key practices for partnering with our community health workers. And that content of a checklist is drawn from the Engage for Equity Partnerships Promising Practices of CBPR guide. And at AMOS, finally, another tool that we use, we're not only interested in measuring how we as an organization partner with the community, but also how our community health workers partner with other community members. So we implement a participatory evaluation technique called the Estrella Comunitaria, based on Dr. Susan Rifkin's work to evaluate community participation in CBPHC. And this tool was co-developed with health promoters to enable them to self-evaluate on the domains of needs assessment, leadership, organization, resource mobilization, and management. Next slide. Okay, so as I referenced at the beginning, just to wrap up, AMOS is really passionate about integrating a reflection, action, learning cycle into all that we do. So this idea of a reflection action cycle is elaborated in the Barefoot Guide referenced here, which we found to be a great resource. And as I mentioned earlier, AMOS's program staff regularly present community collected data from the census or and other sources of monitoring data in meetings with community health committees. And we do this in the form of games in order to make this activity more dynamic and interactive. On the left, I also included another example of data review we do among staff members that Dr. Laura mentioned earlier. They're called data parties. And in data parties, key data in graph form are shared with our program staff for collective analysis and reflection, and everyone is required to wear funny hats. Now, currently, I just want to give you an idea of how we're currently managing this in the era of COVID. So one of our challenges at the moment is finding creative ways to continue this reflection action cycle at a time when it's not safe to be holding meetings in the rural partner communities due to the increased incidence of cases. And so we recently conducted a knowledge, attitudes, and practice survey over the phone with our health promoters related to COVID-19. We included questions on how they currently feel with respect to the situation, what actions they and AMOS can take to lower their levels of fear and anxiety, as well as questions on barriers to taking preventative measures. And we asked them to grade AMOS's response to the outbreak so far. So we followed up on that with key messages over WhatsApp, and we're currently also in the process of investigating additional mobile health solutions for communication and training that might be feasible to implement during the pandemic. Thank you.
Thank you, Elisa, for sharing the information. We have a couple of questions in the chat that we will introduce later as soon as we're done with the presentations. But I'd like to introduce Marisa Alanis. She is the AMOS Donors Relations Officer. And after serving alongside AMOS on several mission trips, she volunteered in Nicaragua on their development and communications team for 1 year. Now she is based in the US, connecting individuals and churches to the mission of AMOS and helping create sustainable change for God's kingdom in Nicaragua and beyond. Thank you, Marisa. The floor is yours.
All right. Thank you, Dr. Roberto. And hi, everyone. Thanks for joining us today. So now we're going to move on and talk about how we finance and fundraise for this work. So as you know, increased financing for your mission can lead to improved health, more effective responsiveness, social and financial risk protection for both your organization and the people you serve, and improved efficiency in your services. So today we're going to focus on system strengthening through building sources of sustainable revenue and establishing long-term partnerships. So on the next slide, we can see where do we start when we are creating strategies for sustainable funding. And if we look at Giving USA, which is the largest study analyzing total charitable giving in the US, you'll see that the vast majority of charitable giving in 2019 came from individuals. So the graphic here shows that 69% of charitable giving in the US came from giving by individuals, but you'll also see that half of the giving from foundations came from family foundations, and 10% of giving came from bequests, which is also from individuals after they pass away. So this percentage of individual giving is actually closer to 88% of total giving. And this is the case year after year, that most charitable giving in the US comes from not grants or not corporations, but through building relationships with individuals. So this is very important to keep in mind when we're talking about how to set up our fundraising efforts for success. So on the next slide, you'll see a chart of AMOS's fundraising in general, and you'll see that a majority of our revenue also comes from individuals and churches. And the majority of church revenue often comes from individual members. Our percentage of funding coming from grants in 2019 was quite high at 29%, but I will emphasize that our most consistent grants that we receive year after year are because of the strong personal relationships that we built with the foundation directors. So the takeaway here again is that building long-term connections with individuals is crucial to long-term sustainability and funding. So on the next slide, you'll see just some ethics to keep in mind when we're forming partnerships for fundraising. Our work is in Nicaragua, but the majority of our donors are located in the US. And these are individual donors and churches who have the desire to channel their Christian values and invest their funds and their time into our community-based work in Nicaragua. So with this, how do we ensure we are forming ethical international partnerships? And So we want to ensure first that our supporters in the US understand how our model is focused on long-term work for true sustainability, building up local leaders over time, not just doing short-term projects for them to be done. It's also important that our work is based not just on faith and good intentions, but that we have systems with accountability and transparency and evidence-based interventions in place. And we promote multi-directional learning. So we want our partnerships to be mutually beneficial, both to the rural communities in Nicaragua and to our partners in the US. So you'll see on the next slide a little bit about our model for short-term missions turning into long-term partnerships. So our short-term missions at AMOS are an important source of funding for community projects, and they're equally important to the ways that we acquire individual donors, as folks are more likely to give to our mission if they've experienced our work firsthand. So a lot of research that you may have seen details the very real harm that can be done when using short-term missions for long-term partners, when using short-term missions without setting up a long-term partnership and without setting up sustainability for the community over a long term. But at AMOS, we've seen that when they're set up in an ethical and equitable way, short-term missions really can benefit the long-term work of a rural community. And the teams that come down and volunteer with us act as catalysts for our health promoters and their health committees, and for community members to continue to organize and work towards improving their health outcomes. So this is just a brief framework of how we've set up our infrastructure so short-term missions can lead to long-term partnership. In short, AMOS plays the role of a facilitator in connecting a church or university partner to a rural Nicaraguan community and facilitating their experience, which includes matching the needs of the Nicaraguan community with the skills and abilities of the mission team, and setting up short-term projects that will help the community advance the long-term goals that they themselves have identified. So the mission team works alongside community members and AMOS staff to make these projects happen. And through this process, they become much more aware of the needs and the strengths of the community. They build relationships with all the people involved, and they care about the long-term outcomes of these communities. So they see opportunities to help, they've established trust with us, and oftentimes they're inspired to turn their values into action by giving. So when the team leaves Nicaragua, they're bringing this energy back to their communities. And this means that AMOS has a unique opportunity to act as a facilitator once again and maintain connections built between AMOS, the rural community, and mission team members, and therefore their churches and their local community as well. So on the next slide, we'll start to talk about how do we use this opportunity to build sustainable funding. So one way that we encourage continued partnership is by helping churches establish what we call an AMOS anchor team or guiding committee. And this is often a group of lay people at churches who are passionate about forwarding their church's relationship with AMOS. And they're often the ones to advocate for and manage the activities within what we call a church covenant. And that is a brief document that states some of the commitments that both the church and AMOS want to uphold. So these church covenants are not binding, but they are a promise to one another put in place to establish long-term mutually beneficial partnerships. So they usually set up the congregation to provide an annual financial commitment, often to sponsor a specific rural community. They can commit to sending regular mission teams, sharing the stories of AMOS with their full congregation, and praying for our partnership and its members. And AMOS in these covenants also states our commitments, which usually mirror those from the church, like being good stewards of the donations they provide, supporting their mission teams, sharing regular updates with the church, and again, praying for our partnership. So another way on the next slide that we're going to talk about building sustainability and strengthening fundraising is through monthly giving. Monthly donors are loyal, quote unquote, donors. They're much easier to retain from year over year as compared to donors that give one-time gifts. And some of you may have really strong monthly giving programs already, but I will give you a few strategies that have worked for AMOS to amp up our monthly giving program over the past few years. So first, you can consider building a program brand. AMOS's monthly giving program, as you can see in the little photo, it has its own logo and name, and it's called the 52 Weeks of Hope Club. And we emphasize how monthly donations help us improve health all year round, 52 weeks a year. So be sure you're advertising your monthly giving program across all your channels and detail the benefits of becoming a monthly donor, which don't have to be tangible. For example, they could include easy automatic donations from your credit card or bank account, the confidence that you're providing sustainable support to this mission. And at AMOS, we send a weekly email to our monthly donors, which gives us an opportunity to share stories and photos from the communities that they're supporting. And my favorite strategy to amp up your monthly giving is using a challenge matching gift specifically for that purpose of increasing your monthly giving program. So at AMOS, we got a group of donors to challenge others to become monthly donors to AMOS. So if someone started a new monthly gift, it would be matched every month for a full year. So we've done 2 matching campaigns like this, and in less than 2 years have doubled our revenue coming from monthly giving, which is really helpful in guaranteeing sustainable revenue and building out your fundraising projections from year to year. So on the next slide, I'll just mention a little bit about how to adapt some strategies in the midst of COVID-19 when folks can't volunteer physically with your organization or you can't travel to meet with them. So first, you can pivot your programming. That's something that we've done at AMOS to connect donors to our work virtually. So one example of something that we did was host virtual coffee chats via Zoom. And these were themed and included a time for programmatic updates from us, but also they allowed our donors the opportunity to network with one another and share their own personal histories with AMOS, which is a powerful tool to help them reaffirm their connection to your organization. So continue to communicate transparently about how the pandemic has affected your current needs. And most importantly, even if your organization isn't specifically working to address COVID-19, your mission is still important and your donors think so too. So don't be afraid to continue to ask for gifts. So the next slide will just show you a few ways that you can continue to keep in touch with us. We wanted to thank you so much for joining us today. And here's some ways that you can stay connected. We send out a monthly e-newsletter, so you can sign up for that by going to amoshealth.org/connect. We're on Instagram and Facebook, and you can find our website at amoshealth.org. So we're going to move on to Q&A right now, but if you do have any questions that aren't addressed in the Q&A, if you want to talk further about anything, you can email us at communications@amoshealth.org, and we can direct your question to the right person on our team. Thank you.
We would like to thank you everyone who has shared, Dr. Laura, Alisa, and Marisa from AMOS Health and Hope. If you just joined us or joined us recently, you are watching the presentation about faith, hope, and love, 50 years of practicing community-based primary health care in Nicaragua. And the organization presenting is AMOS Health and Hope. We have a couple of questions regarding fundraising and regarding also the use of technologies in the community. We will start with the fundraising questions, given that that was the last presentation. It's fresher in our minds. And Marcia from CMMB asks, would you provide an example or examples of those most critical short-term mission goals? Marisa, if you would like to answer that question.
Sure, yeah. So I'm assuming that this question addresses sort of like short-term projects that teams would be working on. And because I said that those projects would fit into the long-term goals. So correct me if I'm wrong, Marcia, but I will give some examples of that. So generally when our mission teams come down, we have them work alongside community members in communities for example, to install water filters or monitor water filters that have previously been installed. There's usually some element of a construction project. So building out an area of the community clinic. There's usually some sorts of activities with kids. So teaching hand washing maybe. So really those are short-term projects, right, that any sort of week-long or so mission team could help with. But really the goal in those is to provide support to the community's long-term goals. So for example, of goals surrounding water and hygiene and sanitation, so making sure that there's clean water. And really when we go in as a mission team, I've been on several myself with AMOS, and when the mission team goes in, the goal is not for them to finish the project and feel good about it. It's for the community to learn, and it's for them to sort of guide other community members to take on that work after the team leaves. So we have, for example, in the water example, water promoters actually that are going along, that are based in the community and will go along with the mission teams. And so really the goal of that mission team is to make sure that that person is empowered and learns about the importance of clean water, and is empowered to continue to serve in their community and be able to address questions from other families and promote that work in the future.
Thank you, Marisa. And although I serve in the board at the moment, in the past I was an AMOS staff, and one of this conversation is bringing so wonderful memories of walking with community members, working with them to do the census or install water filters. And I just wanted to share too that, for example, our water filter project as a short mission term goal, it's a project that it has been identified by the community as an important need of the community that they wanted to address. And it just beautifully, it's beautifully how it couples the programs of short mission teams coming in to work and empower community members to teach them how to install a water filter, how to use it, how to maintain it, and in the long run, like improve health, while a health promoter can remain in the community to continue to work on health prevention in that way. So thank you so much for this question. And we have another question. Could you share, and this is for Alisa, can you share more about if you've had to change your program structures overall during COVID-19, and specifically, what does monitoring and evaluation looks like during COVID?
Yeah, absolutely. So I think some of the most significant changes have been that we can't currently promote community meetings, so no community assemblies or meetings among our health committees. And so that's very difficult, but fortunately our health promoters do have a WhatsApp group in which they maintain consistent communication amongst themselves and with AMOS. And so that's one way that we've kind of continued both the provision of guidance as well as social support throughout this time. That's been really important. And we actually have provided all of our health promoters with smartphones to enable that. And so we charge them with data. Another policy that we've taken recently, given the increase in cases in Nicaragua, is that our health promoters are currently only attending emergencies. And they have a case form to identify suspicious cases of COVID and to refer them out to appropriate health centers. As far as monitoring and evaluation, our health promoters are continuing to fill out relevant forms at their community clinics as they consult with emergency patients. But we haven't been able to go out and meet with them and review that data with them. So they're able to fill out those forms and to send pictures of them to us by WhatsApp so that we can enter into our database and review them. But we are facing a little bit of a lag in getting to review that data with them. And so right now we have definitely been continuing to look at options for new partnerships for mobile health solutions, primarily for communication and training right now, but potentially for data collection in the future. Although in our communities, lack of signal is always a significant issue. So that's the current challenge. Thank you.
Thank you, Alisa. And we have another very interesting question, and please pose your questions if you like to in the YouTube. We are getting them in real time, so make sure that you can ask your questions if you would like to. This is a question for Dr. Laura, and we apologize as Dr. Laura has dropped off for a few minutes. Hopefully she will be able to join us. However, I know that either Alisa or myself can provide an answer to this question. Is from Steve Letchford from Banda Health in Kijabe Hospital in Kenya. And he asks, could you comment on the role that AMOS uses technology or sees that appropriate technology could be used if it was available to help provide health equity to the most vulnerable people, if at all?
Yeah, absolutely. So I don't know, Steve, if you wanted to clarify what kind of technology in particular you're interested in, we can try to speak to that more specifically. But I think in general, yes, we look into adopting new technologies very deliberately and usually through conversations with community members, right, on how this can respond to their particular needs. So our water filters are definitely an example of that. After we'd conducted water testing and identified contaminants and different sources of risk associated with the source water, we introduced point of consumption water filters of different kinds in our communities, and we have a couple of environmental engineers on staff that help to do that analysis to identify, which types of filters were likely to be the most effective. And so that is how our water filter program has evolved. And as I mentioned, we're actually currently evaluating it to determine, which is the most appropriate kind for the context of our rural areas. But that was a solution that came out of a recognition that we have these issues with diarrhea that are associated with unclean water, and we've identified, pollution in source water, but also, potentially even greater risk of a recontamination happening in the piping between the source water and the household. So point of consumption water filters at that time were determined to be the best solution, especially since this was something that community members could actively participate in installing and maintaining. And that's something that's always really important, because the solution has to be something that is owned by community members. They have to, determine that this is the priority and really own the long-term sustainability of the solution. I don't know if there's anything you'd like to add to that, Dr. Tonio.
We have a few minutes, and we are getting more questions now. One thought that comes to mind is, in terms of speaking of technology, I can give two examples. One is the use of cameras, for example, during our photo voice projects, like digital cameras, but also medicines as technology as well. So in the photo voice example, we have used digital cameras. We train community members how to take a picture. And then after they go into the community and take a picture of what's meaningful to them, they come back to the community and they describe what this picture is about and why they took a picture of whatever it was in the picture. And we use that technology to inform the community's plans, as the same, also potential areas of future development for the community as well. And it's a way of hearing what the community is interested. On the other spectrum is like medical technologies, such as, for example, medicines. And we use an antibiotic, amoxicillin, which is very regimented under strict protocols. And in that case, so long that the community has has been trained well, the health promoter has been trained well, and we provide the supervision of that, we are very, very happy to use that kind of technology. The point is that the basic principle is that it has to align with the community's choice, and that it has to align with a long-term plan of the community. There is a couple of other questions. We have a question for Marisa here. You shared a variety of forms of communications with your supporters and donors. If we don't have a communications or development staff person, what do you think is the #1 most important area to focus?
Thank you. Yeah, that's a really great question. So I would say that an ideal communications or development program is balancing two things at once, which is communicating with their top highest supporters, and also building up new supporters. So I think in the short term, though, if you are just, you're needing that funding from year to year, I think that the #1 most important thing is making sure that you're communicating with your top donors, however that may be. So whether it's an email, whether it's sending some photos or an update, or getting them on the phone or on a Zoom call, I would say that that would be your number one priority, is just making sure that you're in good communication and reporting out on things that they helped you accomplish and helped your programs make possible.
Along the lines of partnerships, to Marisa or Dr. Laura, who has been doing partnerships her entire life, there's a question, and it reads, for your partnerships with other groups, are there formal MOUs in place with other organizations or with the government for your projects? Marisa?
So I think this question is probably not so much focused for me. For our actually, Alyssa will be able to speak better to our grants. I will say with our individual donors, we do some sorts of like the church covenants, but not really formal MOUs.
Yeah, so we certainly do have formal MOUs where they're institutional partners, as well as an MOU with the Ministry of Health of Nicaragua. Mm-hmm. So those take a slightly different form depending on who the partner is or the nature of the partnership, whether it's a research partnership or a continuing donor. But yes, they are formalized. Mm-hmm.
Thank you, Alyssa. And Dr. Laura, would you like to add anything about like the formalization of MOUs between partners?
Oh yeah, I think that actually a lot of evidence has been shown. So like if you look at the whole group of CBPR effective partnering principles, there are many specific partnering principles that actually specifically lead to improved outcomes, and having a formal MOU is one of them. So AMOS works very hard on making sure we have formal MOUs with the government and other partners that we're working with. And then in the communities, we have like a little, it's like a flip chart paper where we do a formal, MOU with them when we start working in a community and keep on going back to that. So that has been shown to be one of the effective partnering practices, that you can actually systematically like look at the data on that to say, and that's what we've been trying to move towards at AMOS, is trying to say, as an organization, are we implementing effective partnering practices? And then that's why we started developing like checklists around that, so that checklists wouldn't just be for, hey, are you doing all the diarrhea prevention stuff right and giving the proper medications, but are you also following effective partnering practices? And I think it's very easy to get lost in not doing effective partnering practices or community empowerment, because you're like, oh my God, there's a kid that has diarrhea or someone with a fever, and you get sucked into that. But then if you don't be like, well, how are we partnering with them long term, and how are we, doing community empowerment to build their sustainability? By missing that set, then you don't lead into sustainability. And I do think all these are like measurable outcomes that we should take just as seriously as the number of child deaths we have, because they're ultimately linked.
Thank you so much. We have a very interesting question from Esquias from Brazil. And the question reads, how to build social capital? And when I read social capital, I understand how can we use the experience of the mothers who have a child who died too young due to preventable diseases, in channeling her energy and her knowledge towards the community. Dr. Laura?
Oh, okay. Sorry, I didn't know. I wanted to give other people opportunity too. So when you talk about like those moms who maybe have lost a baby or who have suffered illness and stuff like that, I mean, I think that's what community-based participatory programming is about, right? It's about how do you pull those moms in? How do you, and I don't think that, like I said, as health professionals, as health providers, we're not all trained to do that. That's why at AMOS we work really hard, and it's not been easy, right? I mean, Dr. Tonya knows that. Dr. Tonya has been out there too. It's like, we're like, listen to the community, do this. And the docs are like, no, let's just do the diarrhea stuff. And that's what they focus on, right? And that piece about, and I think to me, that's about developing a workforce that honors and listens to those moms, that brings those moms in, that can build them as part of the community. And it's not easy, right? And I think that's one of the pieces that I think we often forget about community empowerment and, building social capital. It's that's all part of the similar vein of like, you need to start with those relationships, building that trust, working with those moms. And then as they gain your trust, as you start to, they start to recognize you are listening to them, you're bringing in their ideas and thoughts into the system, then you can start building it. But it's not overnight piece, right? And it requires like this long-term commitment, which I think a faith-based organization tends to, I'm not trying to say it's better than a non-faith-based organization, but I think faith-based organizations tend to have less like rigid, like, oh, I'm just getting money from USAID to do this one thing for 3 years. At AMOS, we've been doing the same thing for 50 years, right? Practicing love, faith, and hope in a systematic way, I think, that says we have that next generation of leaders. It started out with Gustavo, then we came on, then we have this new group, and it's like, it sustains itself over time. And I think that's the beauty of faith-based work, is that faith-based work that listens to communities is ultimately like more sustainable, I think, because you're not working off these like 3-year timeframes, right? It's like the kingdom of God. It's like forever.
Thank you so much for all the information shared and the passion and the willing to serve others too as well. We are reaching the end of this presentation. And as we get there, I'd like to ask any of our panelists for a final thought that you'd like to share with our audience today. And I don't know if Dr. Laura, would you have any final thoughts for our audience today?
Well, first of all, thank you so much for coming on and listening to what we had to share for the 50-year history of AMOS. And I just feel like, that the AMOS ministry to me has been an amazing beacon of hope for myself. And I think hopefully for the promoters and others who work with us, because we are trying to be the hands and feet of Jesus, and that's what drives us. Like, what can we do to serve in the best way possible? And I think community empowerment and effective partnership, that's what Jesus was all about, right? Like, he put it in our hands. He was an amazing partner, so he is an amazing partner still. So anyways, that's my last thought to share.
Yeah, absolutely. That's totally our inspiration. Jesus' servant leadership and his proximity, right? And like most of his proximity to people who are marginalized, and consistently treating them with dignity. And the first shall be last, the last shall be first. So thank you all for joining us today. And so we still have a bunch of comments and questions in the chat that we didn't get to. So please stay in touch with us. We're provided that great slide with all the ways that you can continue to connect with AMOS. And if we didn't answer your question fully, then please reach out, and we're happy to set up a call and have a dialogue. Thank you.
I'll just say lastly, from the perspective of giving, we are experiencing unprecedented times right now for charitable giving and for so much of the nonprofit sector. But I'll just encourage you to keep going, keep sharing about your work, and keep inviting people into it, because what you do matters to so many people. And the one thing that hasn't changed is that people want to support that.
Thank you, everyone. And we hope that you enjoyed this session. There are many more sessions on health systems strengthening, community-based programs, and advocacy. If you haven't registered yet, please visit www.ccih.org to see the full schedule and access the registration link. Let's close in prayer, as we are all wanting and willing to devote our life to the cause of service to the poor, particularly, but to the world in general. Let's pray. We thank you, Lord, for this amazing opportunity to gather with friends from all over the world, to be able to think about the ways in which we can be more effective at saving lives, but also at improving them and at addressing the root causes that have people in poverty. May your teachings, the one of love, of grace, a teaching of being with the poor, be in our hearts always, and inspire us to make sure that the missions of our organizations are not just on the walls, but in our hands, in our feet, as we walk with the people that we serve. We thank you for this audience, and we ask special blessings upon them, as well as we ask for blessings for those who are experiencing a COVID-19 infection or that are at higher risks and that don't have the resources to be able to fight the infections. We thank you for your grace. We thank you for your love. In Jesus' name we pray. Amen.
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 Thank you.
Have
Amen.
a good day, everyone.
Thank you.